Okay, good evening, everyone. So today we are starting with our first academic session of the study club of POPMA. And I must tell you that today POPMA has completed 6 months of its inception. And we have our first guest speaker for the first academic session of study club, Dr. Amber Agarwal. Dr. Amber Agarwal is a clinical microbiologist and he has done his MBBS from Guwahati Medical College and MD in clinical microbiology from Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences, Shillong. He was chief of the labs in Dr. Lal Path Lab at Hisar for 3 long years, and after that he's currently working as a senior consultant and the head of the department of microbiology at Manglam Diagnostics, Hisar. And his areas of interest are clinical microbiology is the one whole which he does lot of work in that. He is interested in reducing the pre-analytical errors in the sample collection for microbiology samples, and he also aims to improve the practices of sending cultures to the labs. Apart from that, he is involved with the molecular diagnostics. He has like quite a good expertise in reporting for the molecular diagnostics, in which he does a lot of TB PCR, CBNAT, and hepatitis B viral load, hepatitis C viral load, and HIV viral load. And he does a lot of fungal cultures and the staining part. I think that's a brief introduction of Dr. Amber. And over to you, sir, uh, for your lecture.
Hello. Thank you, Dr. Bhuvan. And good evening, everyone. I should. It's a very nice occasion for me to speak on common techniques in clinical microbiology. It will not be a very exhaustive thing. It will be a brief thing. And see, I'll be discussing some things about pre-analytics, what to send, how to send, which samples to send. Then somewhat about clinical thing, like in the lab, how you process the sample, and little bit about AST. Today we'll be talking about the basics. Okay. So my slide is visible now to everyone.
Yes, yes, it is visible.
Okay. So the introduction part, there are some things such as number one is specimen collection, number two direct detection staining techniques, culture identification and AST, serology, molecular methods, and microbial typing. So in a diagnostic lab in a TA2 setup, things which you can do like on a daily basis are specimen collection, staining techniques, culture identification AST, serology. Molecular methods in a tier 2 setup you can do on POCTs, that is point of care test, such sir as mentioned before, such as CBNAT, or for example BioFire. On those machines you can do. Open PCRs are a bit tough because you need batch testing for that. And microbial typing in tier 2 difficult and means it won't be useful for a commercial lab. Those are done in reference labs. So today we will be discussing something about specimen collection, staining techniques, and culture identification in AS3. First three things. Okay. So, and why it is useful? First of all, identification of the bacteria. Why it is necessary? Because if you identify a bacteria, you need to treat it. And in treatment, again, the antibiotics which you give are different for different organisms. Like as in the future slides, which I'll be telling about gram positive, gram negative, the antibiotics are totally different. Now, for surveillance purpose, why clinical microbiology labs are there in tier 2 city or clinical microbiology labs are there for surveillance purposes. For example, like if somebody has been admitted in a hospital and undergoing, say, let's say, for example, implant operation, and what happens is after 6 months, he or she got infected with methicillin-resistant Staphylococcus aureus. And when we tried to find out the cause, we found that some of the staff had Staphylococcus aureus in their hands. So for that purpose also it is required. Then outbreak investigation. Outbreak investigation, if I would like to give an example, I would give an example of, let's say, a female 40 years underwent an hysterectomy operation, and post-operation at the site, after 3-4 months, there is still some infection, there is still some oozing. On finding out, there was some kind of infection which the hospital gave to the patient. So for that, you need labs. Then to start post-exposure prophylaxis. Post-exposure prophylaxis, if an example is like when somebody is working in a hospital, there can be spill, there can be needle stick injury. In that, you need the serology department and the molecular department to know if the patient was infected, is infected, and who has got the injury, what steps to be taken. And lastly, to initiate appropriate infection control measures. Post-COVID, everybody knows that if somebody is going to the hospital, you might get an infection which you did not have previously. So for that also, you need a microbiology lab. Now, coming to the specimen collection part. Now, during specimen collection, some standard things which need to be followed is standard precautions. Ideally, the sample should be collected before antibiotics have started, but not necessarily. Now, contamination with indigenous flora should be avoided. An example for that is like, for example, let's say you have a wound oozing from your operation site. Then what happens is somebody is taking a swab from that. First of all, it is not ideal. Ideally, swab should not be sent, but still, if that's the only site and you are taking it, you should not take the skin around it. You should clean the area around and then take the pus oozing from it so that there is no contamination with the Coagulase negative staph which is there in the normal skin flora. Now again, coming to the swabs, swabs are convenient but are considered inferior to tissue, aspirate, and body fluids. Now, coming to specimen collection, these are the normal good lab practices which everybody has to follow. Container, when you are transporting, it has to be sealed properly, labeling, at least 2 markers minimum. Rejection, talking about rejection, there are some rejection criteria. Like if we go in depth, there will be too much. Like basic things is like, for example, if you are sending an anaerobic culture, like you have suspected an anaerobic infection from, let's say, from the dental site only. But if you are sending a swab, there is no logic for that culture. The culture for anaerobic culture has to be sent from a like closed space. Like from urine, from midstream urine, you cannot send the anaerobic culture. If you have to send the anaerobic culture, you can only send the suprapubic aspirate. I hope this point is clear, because dental, there is a lot of anaerobic infection. But if in the mouth cavity, if you are thinking to send for an anaerobic infection, like I have not received any sample till now, but for anaerobic infection, because we don't do the anaerobic infections in our lab, for anaerobic infection, if you just give a sample of the swab, I think so it would be rejected. And second of all, if you are even after collecting, for example, if you have collected a deep abscess, you need to send it in a liquid media, Robertson cooked meat broth, to the concerned lab. Now, collection time. Collection time, see, the transport time should not exceed beyond 2 hours. And in some cases, such as CSF, body fluids, ocular specimens, tissue specimens, it should be less than 15 minutes. But practically, it is almost not possible to follow this. So what we have seen is you can send the sample, the temperature, you can keep it at room temperature because most of the labs are not that close by that you can send the sample in such amount of time. However, most of the books have mentioned these time frame so as to which the sample should be sent, and if not sent should be rejected. Like there's a rejection criteria also, but most of the labs don't follow this. Like all the labs don't follow this. Again, for urine, what happens is urine in itself is a media for growth. So what happens is that if a person has given his or her urine, then what will happen is, as in females, the urine does not pass through a clean site, it gets contaminated with the flora, and that flora grows, and that is sometimes reported. So for that, you can send the sample in boric acid. What boric acid does it stops the multiplication of the bacteria present. Now, for stool culture, they say that it has to be transported within 1 hour, but if you send it in a transport media, you can still up to 24 to 48 hours, it can be done. Rectal swabs, they say that up to 24 hours is acceptable. For anaerobic culture, as I have already mentioned, that you need to send in the Robertson cooked meat broth. Now they say if you are not able to send it in that time, you can store it at room temperature, and blood cultures and sterile body fluids you need to immediately incubate at 37 degrees. In this blood cultures, there are two things. One is manual blood cultures and one is automated blood cultures. Most of the labs nowadays are having automated blood cultures. So for automated blood cultures, what happens is that, for example, if you have received the sample at night and there is no staff in the microbiology department. So what happens is you should not incubate it at 37 degrees. What happens is the bacteria will start multiplying, and when you put it in the machine will take that as the benchmark and will sometimes give a delayed positive or a false negative result. So if you are using automated systems for blood cultures, you need to keep it at room temperature, and as soon as possible, you need to put it in your automated blood culture system. Again, sterile body fluids, what we are doing is we are putting sterile body fluids in our automated blood culture bottles for better results. Now, corneal skippings, they say it should be plated bedside. Bedside in the means you can send your blood agar to the ophthalmologist on when they require it, and then they can put it on the bedside. Stool culture, they say that it can be stored up to 72 hours at 4 degrees. Now coming to detection. Now direct detection is as you cannot see the structural details of the bacteria cannot be seen under light microscopy. Only in electron microscopy you can see that. That is why it is necessary to use staining methods. And before staining, when you try to stain a sample or from the culture media, you need to fix the stain, the smear, so that they are not displaced during the staining process. Now, fixation can be done by two methods. It is either heat fixation or methanol fixation. Mostly in microbiology labs, we do not use methanol fixation, we use heat fixation only. And most common techniques, what we do usually is gram stain, and then Zn stain, and then Albert stain is like infrequent, but we still do it. Now, staining techniques. In staining techniques, it can be a simple stain, negative stain. In simple stain, again, you have basic dyes are used to provide the color contrast, but impart the same color to all the bacteria. So not that frequently used. Negative stain, it is like what happens is in negative stain, the background is colored and not the bacteria or fungus itself. And a very common example of negative stain is for cryptococcus, which is used in cryptococcal meningitis. And what happens is the background gets stained and the capsule you can see or visualize. Now, for example, if the organism is too thin, then what happens to make it thicker and to visualize it, you can impregnate it with silver salts. It is mainly used for your the organism which causes spirochetes. In spirochetes, the organism is that causes syphilis. Can anyone tell which organism causes syphilis?
Yeah, Treponema pallidum.
Okay. So for that, you need to use these types of stains. But most commonly, if you say in a lab, it is done by the serology part. And very few labs do this impregnation method. Now, the most common thing is a differential stain. Now, what is the benefit of a differential stain? Differential stain is like you can visualize the bacteria which you want to differentiate. For example, in gram stain, it differentiates into gram positive and gram negative. In acid fast stain, it differentiates the acid fast and non-acid fast. And in Albert stain, it differentiates bacteria having metachromatic granules from other bacteria. In a lab, most commonly, gram stain is performed and then acid fast stain. Albert stain is very infrequently performed. Among gram stain and acid fast stain, it depends on the lab. For example, if suppose it's a TB lab, then they will be performing acid fast stain rather than a gram stain more frequently. Otherwise, gram stain is the most common stain which has been done. Now, coming to the gram stain, it was originally developed by Hans Christian Gram in 1884, and it still remains the most widely used test in diagnostic bacteriology. So there's a picture of a gram positive cocci and a gram negative bacilli. But when you do from a patient sample, then it becomes it is somewhat challenging because gram positive cocci is identified most of the times. But sometimes if the patient is on antibiotics, the cell wall breaks and that can be identified as the gram negative diplococci. So that is one difficulty in patient sample. So if we go for the principle, gram positive bacteria resist the decolorization and retain the color of the primary stain, whereas gram negative bacteria decolorize and therefore take the counter stain and appear pink. Now, what are the uses? See, for example, let's say we have got a pus sample for culture. So we have plated into our different medias. Most commonly used medias are blood agar and a differential media that is McConkey agar. Next day, when we see the colonies, we are not sure that whether it is a gram positive or a gram negative bacilli, gram positive cocci or a gram negative bacilli. So we take the colony and perform a gram stain from it, visualize it under microscope and confirm. And from that, we do other biochemical tests and then we perform the antimicrobial susceptibility test. Now, for example, now if you continue with the same example, today we have got a sample, we have plated, and tomorrow we are getting a growth. So 24 hours has elapsed before you can give anything on culture. So what happens is from that direct sample, if you make a gram stain, like let's say you have got a pyothorax, and in pyothorax you do that gram stain and you can identify gram negative bacilli nicely. Then what will you do is you will give a call to the physician and say that, look, this is a gram negative bacilli. And if the patient, usually nowadays, if the patient are on sepsis, they are put on multiple antibiotics such as vancomycin, linezolid for gram positive coverage and a gram negative coverage of imipenem or meropenem. So if you are pretty confident that you have seen a gram-negative bacilli, then what the clinician can do is can stop the Vanco or linezolid and continue with the gram-negative coverage. Then one more thing is you have identity, and in India mostly it is a gram negative. We are a gram negative country. Like we don't have that much gram positive organism. We have loads of gram negative. So what happens is they will mostly start with a gram negative coverage. Then what you can do is you can say that, okay, look, we are getting a gram positive cocci. So what he or she will do is add the gram positive coverage. So that's what is the benefit. And then is early presumptive identification of fastidious organisms such as Haemophilus, which are difficult to grow. Now, other users are, for example, if you are suspecting an anaerobic culture. Now, let's say if somebody has sent a aspirated pus, right iliac fossa, patient came in with pain abdomen, there is a pus collection, they aspirated the pus, sent to you. You could see a gram-negative bacilli and a gram-positive bacilli, and but next day you are not having any growth. So that suggests, according to the site, a anaerobic infection. Now, gram stain is not only for bacteria. The fungal things such as candida can also be seen on a gram stain, and they look like what you say a gram positive. Gram positive oval shape. The size is a bit more than a cocci. The most important thing of gram stain utility of clinical specimens is the screening in the quality of a sputum. Like most of the labs will always get a lot of sputum for culture. So there are some criteria when you do a sputum culture. Before that, a gram stain should be performed to look for the adequacy. That is, if it should have more than 25 pus cells and less than 10 squamous epithelial cells, or more than 10 pus cells minimum, to say that, okay, look, this sputum which the person has produced is a sputum and not a saliva. So for that, it can also be used. Now coming to acid fasting. Now acid fasting, as we all know, on 24th March, it was the World TB Day. And still acid fasting is the most common requested test for diagnosing TB, whereas the sensitivity is very poor and the specificity is quite high, but sensitivity is quite poor. So what is the reason of the acid fastness? It is due to the presence of the mycolic acid in the cell wall. Now, when we prepare when we perform a ZN stain, first of all is the smear preparation. Smear preparation, for any smear preparation, I would say that it should neither be too thick or too thin. And when we see through it, we could see the print material of a newspaper should be readable. And it is air dried and heat fixed. Most of the things which the smear preparation for TB should ideally be done in a biosafety cabinet, because aerosol production will be there, and that can lead to the person who is doing can get TB. There has been occurrence of staff getting infected, doctors and other persons getting infected. Now the steps for the ZN staining is, the first step is you do the carbol fuscin for 5 minutes. Ideally, what should happen is you should heat in between so that the mycolic acids can give space so the primary stain can go, and you should heat so that you could see the fumes but not the boiling. Then is the decolorization with 20% sulfuric acid, and then the counter stain. Now the Mycobacterium TB appears at long, slender, straight, curved and beaded red color acid fast bacillus. Now let me share a case. Let's say patient has come to you a sputum sample. This is quite infrequent, and you have seen 3+ acid fast bacilli on your ZN stain. Luckily, the patient could afford a gene expert and has requested for a molecular test. And the molecular test came out to be negative. Thankfully, what happens is the lab is subsidized or the lab has funds. They repeated the test and still it was negative. Can anyone think of a diagnosis like uh, your staining is positive, but the molecular test is negative? Any diagnosis? Anyone can think?
Is it could be because of a partially treated tuberculosis?
Yes, look, in partially treated tuberculosis, what will happen is the load will go down. So let's say if today you have done a MTB test, what you call staining test. Today it will be 3+. After 1 month, if that patient has been treated well, responded well, it might come to 1+. And in that way, the stain will decrease. But the molecular test, as it detects the dead bacilli, it will always be positive. So, molecular test will always detect that. Partially treated will always be positive on a molecular test. So that is like I'm looking for something else. Means what other organisms are acid fast positive are, but not Mycobacterium tuberculosis.
Then Mycobacterium leprae,
Lepre,
but again,
the percentage will be different, number one, and number two, clinically, let's say, patient coming with cough, lepre also won't be. Can if somebody else wants to try,
yes, any of the participants want to
can give
answer
a
this?
thought process. Because this, I also got during my practice, like during my post graduation, I never saw that case. Post while working in Hisar, I got not lots, but still we got some cases.
Okay. Mm,
Okay, I'll continue. It's Mycobacterium other than tuberculosis.
okay, some avium complex or other mort.
Yes, yes, more like
Mort.
Mycobacterium abscesses and all,
Okay,
which
fine. Yeah,
mostly
yeah.
mostly they cause infections in laparoscopic site, but in lungs also they are there.
So kindly explain everybody about mort. What is it to all
Uh,
the participants
like
in
what is
brief?
like what happens is, like for example, like I'll just give you a case, like somebody went for a laparoscopic site infection, laparoscopy for let's say an hysterectomy, and after 3 months also she is suffering from SSI. SSI is surgical site infection, and let's say the clinician has given all the antibiotics. They would be treated with linezolid. They would have been treated with ferropenem. They would have been treated with antifungals as well. But what is happening is, finally, they have sent for histopathology and for uh, AFB examination and for gene expert. Luckily, what happened is the AFB was seen nicely, and gene expert came out to be negative. Then they sent it for TB culture. And in TB culture, there are different, like for example, if you have a surgical site, it would be abscesses most common, and some of them are rapid growth. Right now, I don't remember which are the rapid growth, slow growth. So it grew there, and then the diagnosis came out. So this is one clinical tidbit which I want to share, that AFB positive will not always be molecular positive. And the reverse is also true. The sensitivity of an AFB smear is like you need 10 to the power 6 bacilli per ml. Sorry, not 10 to the power 6, 10 to the power 4. 10,000 bacilli should be there per ml of sputum to come positive on a smear, AFB smear. Whereas the latest gene expert, its sensitivity is 11.6 bacilli per 11.6 colony forming unit per ml. So you can see, like if you are sending for a ZN smear and if you are sending for a molecular test, what's the difference? We regularly get ZN, this ZN stain negative, and gene expert positive in extrapulmonary TB from CSF, from joint and other sites. Now there are some modification of acid-fast staining. That is the cold method in which heating is not required. These are used for other bacteria which are acid-fast, such as nocardia. There are other things also. Sometimes acid alcohol is used, malachite green is used as the counter stain, and the concentration of sulfuric acid varies. Can anybody I would request someone to tell other organisms which are acid fast, which are commonly encountered in dental practices.
First is Mycobacterium tuberculosis, then Mycobacterium leprae.
Whole mycobacteria we can classify as one group.
Apart from Mycobacterium group, you are asking AFP positive.
Yes. Which has mycolic acid in its cell wall. This was my PG question, like CMN group of bacteria. CMN stands for Corynebacterium, Mycobacterium, and for Nocardia. Nocardia is a type of
Is histoplasmosis,
histoplasma
plasma capsulatum is acid fast
this I would have to
fungus.
I would have to go back. Other organisms which are acid fast are your parasites.
Okay.
Cryptosporidium.
Okay.
Cryptosporidium, Isosporus. I know means you all have not encountered.
Yeah. One of the participant is saying Cryptosporidium.
Yes. There's a good MCQ also, and what happens is, like, if you have a patient who's immunocompromised, and then what is happening is they are having diarrhea, like continual diarrhea. Continual diarrhea means chronic diarrhea. And then what happens is, most of the time at the pre-lytic stage is the sample is sent for routine stool culture, but is never sent for the modified acid fast staining. So that is missed. So that is why it is useful, but it all depends, because regularly in every patient we cannot send for cold method. Nah, it won't it won't happen. So in specific cases only it needs to be sent. Now coming to the Albert stain. Albert stain is used mainly to diagnose Corynebacterium diphtheria. Has anyone seen a case of Corynebacterium diphtheria? Like at least
one case, long back. It's very, it's not. One ENT person used to send, and that time it was declared as endemic for our area. That's why I've seen one case. From the pseudomembrane, it was oropharyngeal.
What happened is, what happened is, when you do the stain from the direct pseudomembrane, the metachromatic granules are not that visible. You will only see gram-positive bacilli kind of a thing, and sometimes V-shaped, those Chinese letter patterns. What happens is, when you put it in the Loeffler serum flow, it's a nutritionally deficient media, the metachromatic granules will become prominent. And after 6 hours from that Loeffler serum flow, when you make the Albert stain, at that time it becomes prominent. So that is one, again, means practical how you can distinguish, because what will happen is, a lot of times there will be a pseudomembrane. Pseudomembrane, you will get an Albert stain for direct. We will be seeing gram-positive bacilli. We will think it is a normal flora or what else. We are not seeing the metachromatic granules. It would be given as negative. But ideally, it should be inoculated in the Loeffler serum flow, and after 6 hours, again, it should be made, and at that time it gives very nicely. So there is a procedure. Initially, the stain has to be made. The smear is covered with Albert 1 and Albert 2. Someone calls it as Albert A and Albert B. And then you look for the bacilli which appears as green colored bacilli arranged in Chinese letter pattern. Now again, most commonly it has to be differentiated from diphtheroids. Diphtheroids are usually what happens. If I have to say that it is a diphtheroid or it's a Cornybacterium, I always say that if those are parallel to each other and everywhere it is parallel, then those are diphtheroids, because Cornybacterium are never parallel, will not always be parallel, but diphtheroids are always parallel. So this is one way of differentiating. Now, staining this much is sufficient. So let's say again, let's take the Cornybacterium example only. Cornybacterium, there was a case. Again, they send the swab from the pseudomembrane. We did the direct gram stain, Albert stain. We could not see any bacilli, which was suggestive of Cornybacterium diphtheria. Then we put it in the LSS, Loeffler serum probe also. There also we could not do. Identify during inoculating into Loeffler serum probe. Okay, it's already 6:40. I was just seeing the time. Dr.
So,
Mohan, it's already 6:40.
no issues. You carry on. It is still 7.
Okay,
And,
okay. So
explain in between the KOH part also for fungus, because we do encounter a lot of fungus in oral cavity.
okay.
Yeah, you go ahead with that.
Okay. So what happens is when you inoculate into the you inoculate it into the media, that is the blood agar and the media, potassium telluride media. So you have not seen in the direct, but next day when you come in the morning on the potassium telluride, you will see black colored colonies. It means that the telluride has the telluride conversion has taken place, and when you make a gram stain from it, you could see that gram positive bacilli and the Albert stain becomes positive. So here comes why you need to do a culture, because the gram stain sensitivity is less. That's why you need to do a culture. And from that culture, when you isolate the pure colonies, then you could go for the antibiotics, which antibiotics to put. And from that, you can say, okay, you need to give this antibiotic. Now, culture media, there are liquid and solid. Most commonly used medias are solid. Liquid medias are used as a transport media generally. And in the lab to inoculate like peptone water and this, your DHIV. Now, based on the consistency, it is liquid, semi-solid or solid. Now, there are some pictures of media which like EMD or McConkey, XLD, blood, chocolate, and Newton. Commonly used in the labs are blood agar, McConkey, XLD for stool. Chocolate is also used for fastidious like Haemophilus in CSF. Nutrient agar and EMD is not that commonly used. Now, I'll be talking about blood agar. So, blood agar mostly nowadays most of the medias can be commercially prepared. Commercially, if you procure them, would be expensive. Blood agar, because if you are going to make, you need sheep blood. So sheep blood is not easily available. You need to have a animal house. Mostly animal house is usually available in medical colleges. So from there you took the sheep blood and basically you prepare 5 to 10%. So 5 to 10% is like if you are preparing let's say 200 ml of media, you need to put 10% of 200, that is 2 ml. So it's not that a huge requirement. Now, why in which media is required? It tests the hemolytic property. That is the alpha hemolysis or complete beta hemolysis. Can anyone give an example of beta organism which is beta hemolytic? No. Okay. So we will see. I will just take some like to some questions in between. If somebody knows, can answer, or I'll move through. So beta hemolysis most common seen by staph. Now what happens is most of the clinical labs use human blood agar. They don't use sheep blood agar. In human blood agar, that beta hemolysis is not pronounced. That is why the staph is missed. Like most of the time there would be infection in the wound. You are suspecting a staph and you have used human blood agar. So you cannot differentiate between staph aureus and Coagulase negative staph, because the hemolysis is not proper. So that is why if you use sheep blood agar, in sheep blood agar, the hemolysis is quite good. Now chocolate agar. Chocolate agar and chocolate agar again can be commercially prepared, and the difference between, if you want to prepare chocolate agar, how can you prepare is, let's say when you prepare the media, you cool the media and then you add the blood. Let's say if the media is not that cool and you have added the blood, what will happen? The blood will split and release it ingredient, it will become chocolate. So if you are preparing blood agar, you put it at like 40 or 45 degrees. And when you prepare chocolate, you put it at a higher temperature, that is 80 degrees, 70, 80 degrees, it will become chocolate. Now, in which media I have talked about Loeffler serum flow and blood cultures. Most commonly available, see, before blood cultures were conventional, that it used to be in glass bottles. But now most commonly used are automated blood culture bottles. Like these are provided by various companies and has to be utilized in their systems as well. It's not an open system. Like there are few companies I'll be mentioning. If you are using that company's blood culture bottles, you have to put it in that company's system only. Now, transport media. Transport media, why it is important? Because look, you won't have a lab next to you. It would be sent far away. So for that, you can use transport media. Now, blood culture media, why other samples you send in a normal container, blood and sterile fluids, you put it in blood culture bottle because the organism load is low. So it might not grow in a direct media. You put it in the liquid media, it goes in the automated system, incubated, and it comes positive after some time if the organism is there. Now, what are the benefits of the blood culture media? It is more sensitive, rapid, and less labor, because manually what happens if you are getting in the manual bottle, ideally they say that it has to be subcultured after on the second day, on the fourth day. Just 1 second. Yes. Wait, just 1 second. Yes. Okay. Yes. Yes. And it is because the automated systems are less labor intensive, because in manually you have to subculture, which can introduce contamination as well. Now,
I think Dr. Amber, your one slide was there before. You can explain about the backtech, the newer technique.
see, backtech is, these are automated systems. In automated systems, what happens is usually, see, when you have done a manual culture, in manual culture, what will happen is today morning you have seen the bottle. At the max in the evening, you will see the bottle and you will shake and look for turbidity. When it is still, you will look for the turbidity, and then next morning. So the preferable time when you see a turbidity is around, like say, 8 hours or 6 hours or 12 hours. But when you do an automated system, the automated system, it checks the monitor every 10, it checks for the thing every 10 minutes. Just 1 second, wait, I'll just pop it. So what happens is it checks every 10 minutes and flags. It has a polarimetry detection and fluorometry detection. This is technical part. What usually happens is, for example, if you practically say, if I get a blood culture today morning manually, what I'll do is I'll incubate it, and tomorrow morning I will make a gram stain or I will subculture based on the turbidity. Automated system, what will happen? Morning you got a blood culture, you put it in the machine, it will look for growth every 10 minutes. And when it goes beyond the level, it flags positive. So what we have seen is, let's say today morning you got a blood culture, by evening 5 o'clock it flags positive, you do a gram stain, you see a fungal organism candida, you inform, patient is started on antifungals. So here lies the benefit of automated blood culture over a manual blood culture. Manual blood culture, what will happen is next day morning you will do something. So that's the benefit. Now, manually, there are some methods when you say, let's say, get the organism or get the sample, there are some methods such as streak culture method, lawn or carpet culture, liquid culture, and stroke culture. Now, how do you inoculate the specimens? Like if you get a sample, how you inoculate it into various media? Most commonly used media are blood agar, McConkey agar, and for urine we use CLED agar, that is cysteine lactose. I forgot. Clade. We call it clade agar. Okay. Now what happens is you take the bacterial, the loops are made of platinum or nichrome wire, and first you heat it, then you cool, and then you take the sample and plate it in the media, plate the media in a zigzag manner. And all of these things should be done in a biosafety cabinet. Now, biosafety cabinets are different types. These are class 1, class 2, and class 3. I guess everyone has worked in a biosafety cabinet.
Just
See,
seeing.
biosafety cabinet, again, in our college also biosafety cabinets were there, but not functional. So biosafety cabinet, if you see the class 3, class 3 is like fully, you see the hands in between the two figures you see in which the hand has to be put and worked upon. Class 2 biosafety cabinets are generally available everywhere. Now, after plating, how will the organism grow? It needs a certain temperature. So most commonly, they are done at 37 degree Celsius. Now coming to the next day, you have incubated. Now you have got some growth. Now, how will you identify what growth it is? Most commonly, there are two things. One is gram positive, one is gram negative. For gram negative, the most common tests used are indole citrate, triple sugar, and urea. For gram positive, these are the tests used. Like if you ask me practically, see the gram positive organisms identified in the lab are very few. Staphylococcus aureus, Enterococcus. In Enterococcus, you have two things: Enterococcus faecalis, Enterococcus faecium. Streptococcus, you have 3-4 species: Streptococcus agalacti, Streptococcus pyogenes, Streptococcus pneumoniae. So for these now you need few tests to identify. And if you ask me nowadays, what is happening is you are having automated systems. If you have got the good pre-analytics, you have got the sample properly, you have used the good media, you have plated it properly, and you have got isolated colonies. So a lot of identification is done at the colony part, because staph will give a different colony, Enterococcus will give a different colony, Streptococcus will give a different colony. And according to the specimen, for example, a CSF is there, you have got an alpha immunity colony. It can be strep or entero unlikely, most probably strep. A pus, beta hemolytic, it would be staph. So you chop down two things, and then to further identify, you do particular test. It's not that for every gram positive you have to put all these 5-6 tests. It is not possible, plus it is not viable. Both the things. There is a like algorithm. For example, you saw gram positive cocci, then you do catalase. Catalase positive, it goes towards staph. Streps are ruled out. Strep and entero ruled out. Staph, now you do catalase has been done. Now you do coagulase. Coagulase positive, you get staphylococcus aureus. Coagulase negative. There are a lot of cons. Cons can you identify manually? You can. Biochemicals are there. Quite tough. Not done. You put it in a automated system, Vitec. It gives the species identification as well. Now, this is how the streaking method you do. Various streaking method. Now, again, according to samples, you have to streak differently. It is not that every sample has to be streaked like this. Now, I was talking about identification. These are the automated methods for identification. Number one is MALDI-TOF, Vitec, Phoenix, and Microscan. Has anyone heard about Malditoff?
I have heard, but I have not used.
Malditoff is like it's like it's one of the functions is to identify the bacteria, but it
Okay.
has got many other uses as well, and it is used in the what you call in the biochemical lab. I'm not using the right word, not biochemical, but it is used extensively there. But in the microbiology lab, it is used for bacterial identification, and now it is used for the resistance patterns also. Now, Vitek is the most commonly used instrument in the microbiology lab. Most of the automated systems are Vitek, then Phoenix. Microscan is few. Now, Malditoff, what's the benefit? It can identify the bacteria, fungi, and even mycobacteria. You have got a growth from the midget, the liquid machine from which in which TB is there, and if you put it in mild, it identifies even the mycobacteria species, and it's quite good. It can identify the fungus as well. For example, fungus you identify phenotypically, but this identifies the species level as well. And mild is available in two companies, that is the Vitek MS, Biomero, and the Biotyper type, that is from Bruker. Now you have identified the bacteria. Okay. Now, let's say if a patient is having a gram-positive infection with enterococcus, and the patient has been given vancomycin, which is a very common drug, but still the patient is not responding. What can be the reason? See, the reason most common, the commonest reason which we can say is the patient is not taking the antibiotic is at fault, means the antibiotic is spurious, all that things let's keep aside. All those things are okay, but still the patient is not getting okay. The most common reason is resistance. That is vancomycin resistance. It is commonly called as VRE, vancomycin resistance, enterococci. So vancomycin enterococci is also there. Now, antimicrobial susceptibility test can be done by phenotypic methods. In phenotypic methods, it's the dish diffusion, dilution test, epsilometer or e-test. Automated systems are Vitek, Phoenix, Microscan, and genotypic methods are PCR for detecting drug resistance. Now, phenotypic is the most common method used in tier 2 setups. Tier 1 setups, they have moved on to automated system. Practically, if you ask me, automated systems are better because anything which is done manually has many points, checkpoints which you need to check every time, which is not manageable also. Now I would just, for 2 minutes, I'll talk about the KOH. I had not included in this. In KOH, what happens is, most important is the sample sending. What happens is, usually what happens is somebody has sent a nail. And what you do is you put the KOH and you immediately see. KOH should ideally be seen according to the sample type. It should be incubated in the incubator. For example, if you have a sputum, you can see it within half an hour because the KOH, what it does, it digests the cells. For nails, at least 24 to 48 hours with a 10 to 40% KOH, you need to digest the surroundings so that you can see the hyphae. I guess, Dr. Bhuvan.
Yeah. So nice presentation by Dr. Amber. He has included the direct staining part, which includes ZN staining, gram staining, then our cultures in which different types of media have been discussed, then the differentiation of the bacteria based on the hemolysis part and other tests. The automation part have been included. If you want to add on or these are the common techniques. So pertaining to our oral region, anybody has any clinical scenario or any question related to microbiology they can ask? I think I'll just flip through the chat box. Mm, yeah, KOH part was told. Yeah, and the complete hemolysis part was told by Dr. Divya. Streptococcus, Staphylococcus, and we do encounter a lot of candida cases. So, what should be the ideal way of sending the sample, and like, shall we go for fungal culture? And secondly, what are the indications for a blood culture?
See, number one is Candida. Na? If you ask me, it can easily be seen on a gram stain. Differently
Okay.
sending KOH for Candida.
But
I
sometimes we do get lot of white lesions in the oral cavity. So to differentiate, there are many other methods also, but the confirmatory, which we say that the gold standard is the culture in or the molecular tests also. So I hope
see
you
it.
have understood my question, which I mean to ask.
Yes, like see, from my point of view, if I have a lesion, first of all, in the mouth, I would be only sending a swab. I
Yes.
can take a swab. I won't be able. If I'm able to cut, it will go for biopsy. If I mostly, I will be taking a swab. So from swab, the easiest part is number one, stain. Number two, culture. PCRs from swab can be done, but because the swab material is very inhibitory and PCRs are expensive, let's put it aside. And KOH. Now, KOH, the main function of KOH is to see things which are hidden, to kill the debris or to eat the debris so that the hyphae are visible. Whereas Candida, if it is there, you can easily see on a gram stain. Why hyphae is not seen on a gram stain is, first of all, the gram positivity. Number two, all the proteinaceous part that also like sometimes get confused. I know it's not that confusing, but if see, I always get this esophageal thrush, these esophageal scrapings from endoscopy, and I
Okay.
always report Candida on a gram stain because it is easier. Whenever you
Yes.
see
Yes.
something on a differential stain, you pick up things faster. Whereas in KOH, if you want to make it a differential stain, add methylene blue.
Okay.
Because if you add methylene blue, you will have a different background na, to
Mhm.
look for Candida. It will become easier.
Okay. Fine. Yeah,
So
and
I feel,
what are the indications for blood culture?
see, blood culture should only be sent if there is sepsis.
Okay,
So if local lesion won't give you blood culture positivity. We
fine.
have identified blood culture positive in neonates Candida,
But
but
there are many times that during sepsis also the culture has been sent, but again it comes out to be sterile.
yes, yes, yes. The culture positivity has to be like ideally three pairs has to be sent. Means 40 to 60 ml of blood for culture has to be sent. That's the ideal. In that, you will get more than 90%. But in India, you send one blood culture bottle that to, if we are lucky, we get 8 to 10 ml, but maximum we get 5 ml. So our
Mhm.
positivity comes down. Moreover, what happens is timing of sending the sample. If you
Mhm.
send a sample from the emergency or from the OPD, your positivity will come. But if you send a sample from after 4 or 5 days of antibiotics, which is usually the case, it becomes tough to get the organisms. And positivity is a concern. Positivity is a concern, will be a concern till, because as I was talking about prelytics. So till the prelytic part is improved, positivity will always be a concern.
Okay. So there is one question by Dr. Arushi ma'am. She's a practicing oral pathologist from Kota. She has asked that kindly tabulate media for collection of oral scraping for fungus and aspirations for culture and sensitivity, which can be told to the general practitioners so that they can go for microbiological investigations. So if not now, you can just put it up in the group as you are an
Okay.
esteemed member of POPMA. So it will be easier for the general practitioners to like uh, use their microbiology knowledge and take microbiology services also.
Sure. Okay, please put the question in the group. I'll just.
Yeah. I'll
Because mostly what happens is there is no different media for collection for fungus. But still,
the
I
only
just put
thing
in the
that you
group.
explain about that when we take any and is there any media for collection of oral scraping from for fungus or whatever the aspirations
Okay.
of pus? Okay, so those
Okay.
points you can just
Sure.
share on the group also.
Sure.
So yeah, thank you very much, and I'll just share my screen. I think you can exit out if
Stop.
possible.
I'll stop sharing.
So thank you so much, Dr. Amber. This is your certificate.
Thank you.
Yeah, thank you so much. Uh, okay, then.
Thank you, Dr. Amber.
Thank you.
Yeah, okay. Thank you so much, everyone, for participating. Yeah, and then for the next session, we will be having in the month of June, and Dr. Joitha sir will be the guest speaker in that. Okay, see you then. Take care.
Thank you.
Okay.